just finish the benign hematology and we will start malignant hematology. From a practical point of view, definitely you are more concerned with benign hematology rather than malignant hematology. In malignant hematology, we have a few points need to be addressed, maybe faced at emergency room. So we usually stress on emergency situation, which is what you are faced at emergency department. Leukemias. Learning objective, what is leukemia? At the end of this lecture, you should know what is leukemia, how is it classified, what are the common presentation, what are the emergency presentation, how can you diagnose leukemia, and you should know some simple outlines on the management of leukemia. Leukemia, by definition, is a clonal malignant disorders. Clonal malignant disorders result in proliferations of abnormal cells. The proliferation of abnormal cells will result in impairment, production of normal blood cells. This is a WHO classification of acute leukemia. It is not important to study this classification, but just see this diagram. So complicated. We classify leukemia into two types, into myeloid leukemia and into lymphoid leukemia. The myeloid leukemia, we name it as acute myeloid leukemia, AML, while the lymphoid leukemia, we name it as acute lymphoblastic leukemia, ALL. So acute leukemia roughly classified into two types, AML and ALL. We can sub-classify leukemia in general into acute versus chronic. We have acute leukemia and we have chronic leukemia. This depends upon the proliferation of cells, time of cells proliferation and division. The acute leukemia, as we said, can be classified according to the lineage, to the origin of the cell, into ALL or AML, while the chronic leukemia into CLL, chronic lymphocytic leukemia, or CML, chronic myeloid leukemia. So we have four types of leukemias: AML, ALL, CLL, CML, according to the chronicity and the lineage of these cells. Epidemiology, incidence of leukemia is 5% of all cancer. According to the age, myeloid leukemia is usually targeting adults, while the lymphoid leukemia usually targeting pediatric. So AML is common in adults, while ALL is most common in children. What about the causes? Why a patient attracts leukemia? Some of causes can be explained by exposure to ionizing radiation, benzene, chemotherapy, viruses, or patient with Down syndrome. These are the proposed etiology of leukemias. Acute leukemia. The definition of acute leukemia versus chronic leukemia, we have failure of cell maturation. You know that the cell inside the marrow get maturation from primitive cells to more mature cells. So the definition of acute leukemia is the failure of the primitive cell to mature, to get maturation. So failure of cell maturation. The result will be accumulation of these primitive cells inside the marrow, will not mature. So the accumulation of these primitive cells inside the marrow will compete with the normal cells inside the marrow, resulting in what we call it bone marrow failure. Failure of cell maturation resulting in accumulation of primitive cell, and the end will be bone marrow failure. Imagine that if we explain the maturation of primitive cell inside marrow, and we take the picture of a human. The human being is starting from childhood, adulthood, and then get older and older. Suppose that there's this maturation from childhood to adulthood impaired. What the result will be? يعني تصوروا المفروض الأطفال يكبرون يصيرون بالغين، وبعدين البالغين يروحون يتخصصون كل واحد إلى وظيفته، اللي يصير طبيب ويصير مهندس ويصير معلم ويصير محامي ويصير قاضي، وكل واحد في وظيفته يؤدي الفانكشن مالته. نفس الشيء cells inside the marrow, starting from childhood as a primitive cells. بعدين these primitive cells get maturation، تكبر cells ويصير بها functioning cell، تتحول إلى ما يسمى بالfunctioning cells. الfunctioning cells اللي هي cells اللي تعطينا نتائج، مثلا الوايت بي سي تبدي بmature cells بعدين تنتهي بوايت بي سي. The function of white BC is defense mechanism. فإذا هي أصلاً failed to get maturation راح يصير النتيجة إنه كل ال primitive cell inside marrow and you have no white BC, no functioning white BC, and the infection will be very high. There is no RBC, there is anemia, there is no platelet, there is bleeding. فمثلاً المجتمع لا يكبر ولا يتطور ويبقى المجتمع كله أطفال، يعني الأطفال لا يكبرون، فتروح للمدارس تلقاها أطفال، تروح للكليات تلقاها أطفال، تروح للأسواق تلقاها أطفال، المدن مليئة بالأطفال، ماكو maturation. هذا الأطفال إيش راح يسوون؟ non functioning الأطفال، راح يصير primitive cells، راح يصير النتيجة إنه failure بالمدن. صح؟ المدن يصير بها failure. أنت المدن قائمة على الفانكشن، على الإنسان الذي يقدم سيرفيس خدمة. فإذا هو أصلاً طفل ما يقدم سيرفيس راح يصير failure of maturation with failure of function، فيصير collapse inside the marrow، فيصير no HB, no RBC, no platelet, no function of platelet, there is bleeding, no white BC, there is infection. This is the principle etiology of patient with acute leukemia. Accumulation of failure of maturations. So the three lineage suppression, no RBC, no white BC, no platelet. So there is low white BC, and when the white BC get low, there is a high risk of infection. Low RBC, and this will result in anemia and low platelet, and definitely when the patient get low platelet, there is a high risk of bleeding. Or those primitive cells go outside the marrow and infiltrate an organs, infiltrate lymph node, result in lymphadenopathy, infiltrate spleen and liver, result in hepatosplenomegaly, or maybe even reach to more important sites, CNS, and resulting in CNS involvement rather than AML. AML signs, because of infiltration of these tumor primitive cells to the skin, this will result in what we call it a mass lesion, tumor of leukemic cells in the skin, called the scleroma. And the scleroma is usually, according to the classification of AML, we have from M0 to M7 AML. This is a sign of AML M2 scleroma. While the AML M4, M5, the infiltration will be in the gum, resulting in gum hypertrophy. And in AML M3, there is a specific sign, and this is the most important subtype of acute leukemia, AML M3. This results in 3 letters, DIC, disseminated intravascular bleeding. This is a picture of gum hypertrophy. Feature infiltration of the blast to the gum. This can be seen atrophy. One of the most important signs of acute leukemia on 4 and 5. Investigation. How I investigate those patients with suspected acute leukemia? Usually with elevated white BC reaching above 15, resulting in 100,000 or more. Or white BC may be normal or even low with anemia and erythrocytopenia. The blood film is the most important tool to diagnose acute leukemia. There is a primitive cells in the blood film called the blast. These are the blasts. These are the abnormal large primitive cells inside the bone marrow. These cells are the malignant blast cells, the primitive cells that fail to mature and get accumulation inside marrow, compete with the normal bone marrow cells, resulting in pancytopenia and the feature of leukemia. We need, after blood film, to do what we call SIML. Is the definition of acute leukemia in general is depend upon what we call it blast cell more than 20%. The definition of acute leukemia depend upon the blast more than 20%. How can you differentiate between AML and ALL? This depends upon special stain, Sudan black and MPO, which is positive in AML, negative in ALL, or presence of our rod cells. And the presence of the our rod cell is a diagnosis for AML. These are the our rod cell, a rod inside the blast, accumulation of granulated tissue resulting in rod-like عصي مثل العصا. These are, when you see our rod, it is AML. Don't need a further investigation. This is a diagnostic clue, AML. So confirmation, how do you confirm the diagnosis will be established by what we call immunophenotyping of flow cytometry, moleculogenetic, cytogenetic, chromosomal abnormality. This is a postgraduate, more detail about it. Differential diagnosis of a case of acute leukemia could be this is lymphemia, severe lymphocytosis due to infection. Whatever the cause behind, when you have a pancytopenia abnormal cell in the peripheral, this could be malignant versus infection. Management. Definitely, supportive measures. This is at the first top of the list of the treatment. What is the supportive measures? We can give it A, B, C, D, E. A, B, C, D, E. A, allopurinol is a xanthine oxidase inhibitor because the blast has a high turnover of urate, and this results in urate nephropathy. To protect the kidney from the effect of the urate, you should suppress urate production by allopurinol. A. B, blood and platelet. You know that they need blood and the thrombocytopenia fusion. This is B. A, allopurinol, B, blood and platelet. Because of the suppression of white BC, Your patient fungal infection, you need to give him antifungal agent, conazole group, fluconazole, because of the accumulation of the plus and risk of urate nephropathy. Allopurinol alone is of no value. You should supply it with high fluid, with dextrose water. VC is suppressed not to treat the patient with empirical antibiotics. Dextrose antibiotic. This is the specific treatment deeper than this intensification, maintenance therapy, and we may need even a CNS prophylaxis. This is the course of treatment deeper than this. What is the outcome of patient with acute leukemia? Acute leukemia, we have a good risk, poor risk, intermediate risk. The good risk leukemia is pro-myelocytic leukemia. As we mentioned, it is M3, AML, M3. And this is leukemia. Yes, it is a cancer and it's a malignancy, but yet it can be cured. We can cure patient with leukemia. It is not a very poor prognosis. This depends upon the risk factor. Again, this slide just to see that acute leukemia have a good risk. It is not almost always a bad prognosis. يعني لا تحفظون هذا السلايد ماكو داعي تحكيشين. We may have a good risk leukemia that the patient will be survive and even cure. Still leukemia, according to the risk stratification, is an incurable disease. If we took this here a case of acute leukemia. A week ago, I presented to you with fever. What's next? And you facing Ali. What do you want to send for? What is next? صفحة the HbS7, the total white BC after chemotherapy, and the platelet is 5,000. We have anemia, and we have a severe thrombocytopenia, a 3 elements suppressed by chemotherapy. So this is a diagnosis of what we call it a neutropenic fever. Fever more than 38, lasting more than 1 hour. Neutropenic patient. When you face this is a super emergency situation. Neutropenic fever. Definitive is an example, and broad spectrum penicillin. The organs most commonly associated with severe neutrophilic sepsis are gram-positive bacteria, Staph aureus, Staph epidermidis, which are presented on the skin. Bacteria and severe neutropenia. While the gram-negative infection often originating from GI tract, the monas are resolved after 3-5 days. Empirical is responding. So Ali was also so high agent. If we the diagnosis of acute leukemia inside moral, as we mentioned, need 20% of blood bulbable on the axillary additive of abdominal exam to the laboratory ratio HB10 7. On ML or ALL, definitely because of the presence of the OROs, this is the AML case. It is M3 leukemia. This is the other name of acute AML M3. As we mentioned, that AML M3 is associated with
طبيعي.
M3, the acute paralytic leukemia is usually associated with DIC. Good. Extramedullary involvement. I mean when the blast infiltrate organs outside the marrow. Feature suggestive of M1, M3, M7, M4. What could be? When the blast infiltrate.
تردي.
Good, AML M4. This is a blast infiltrating the gum and gum hypertrophy, and this is a acute leukemia with extramedullary involvement. Very good. Okay, so by this we just finish acute leukemia, and we will enter in chronic leukemia. As we said, that acute leukemia is usually attacking young patients, failure of maturation, accumulation. So this all is presented here as an elderly man to an emergency situation, otherwise he is healthy. During investigation, this patient found to have a very high white PC count, normal white PC count, 11,000, he has a 61,000. Elderly, otherwise healthy, diagnosed incidentally with high white PC count. The HV is normal, 12.5, and the platelet is normal, 340. The only abnormality here is isolated high white PC count. There is a very high white PC count. Next, what's next? We see the all lineage of white PC starting from neutrophil, myelocyte, metamyelocyte, and basophil. All the spectrum of white PC appear in blood film. From neutrophil to basophil, neutrophil, all the blood patient, we find a big spleen. There is a splenomegaly. So, an elderly with the blood, a full spectrum of white PC lineage, and splenomegaly, this is a classical diagnosis of CML, chronic myeloid chromosome positive myeloproliferation, an adult from 30 to 50. CML, this is this picture show a chromosome called Philadelphia chromosome. It is and the chromosome is 922 chromosome. There will be a translocation from translocation 9 from 20. So CML, it is a Philadelphia chromosome. The Philadelphia is a translocation 922. This is the diagnosis to PCR, resulting in ABL-BCR-ABL. This translocation is targeted by treatment called tyrosine kinase, BCR-ABL gene. This is a gene resulting from translocation of two chromosomes. When this by special treatment of tyrosine kinase called tyrosine kinase inhibitor. So what is CML? CML is a Philadelphia positive myeloproliferative neoplasm. What is a Philadelphia chromosome? It is a translocation of 922. This is a chromosome 22, resulting in a special gene called BCR-ABL gene. And this gene later on will treated by BCR-ABL inhibitor. We are dealing with leukemia that has a low level of proliferation, slowly develop leukemia. The leukemia is a slowly This CML, chronic myeloid leukemia, have three phases. The first phase is the chronic phase. The leukemic cell is slowly proliferated. So there is no obvious symptom in those patients because of slowly proliferated. But this chronic phase may enter into more active phase. We call it may go more faster to accelerated phase, or the most bad phase is the blastic phase, when the cells are proliferated more rapidly and result in acute-like leukemia. It is CML, it's chronic leukemia. But maybe this phase, the chronic phase, will be switched to more accelerated and even result in the blastic phase or acute transformation. The chronic leukemia will transform to acute leukemia, and this is called a blastic crisis or blast phase. So CML has 3 phases: accelerated phase, and maybe go to the more blastic phase. The chronic phase is usually patient asymptomatic. Often the patient of survival reaching 5 years. When this phase is good number, resulting in accelerated phase. The patient started to develop fever, bone pain, progressive splenomegaly, and the survival will be reduced from 5 years to the 9 months. And the most bad phase is the blastic phase, when the level will be more and more less. Investigation, we have usually the full range of granulocytic precursor from myeloblast to mature neutrophil, as the previous slide show all spectrum of white PC, who may be associated with eosinophilia and basophilia. So when you with a full range of granulocytic precursor. So when you have a high white BC and the blood film show the whole spectrum of full range of granulocytic precursor from myeloblast to mature neutrophil with eosinophilia and basophilia, think of CML. So how can you confirm the diagnosis of CML? You think there is a CML, how can you diagnose it? Definitely you would go for bone marrow. This is a procedure. We took a blood sample from the inside the marrow, from the posterior superior iliac crest by this procedure. Searching about what? A Philadelphia chromosome 20. Searching for any dislocation, translocation from chromosome 9 and 22, which is, call it a Philadelphia chromosome. And the Philadelphia chromosome resulting in a BCR ABL targeting cells. How do you treat? Definitely, chronic phase need a عندنا مركز الاورام نطيل المرضى يسمونه جليفيك، المرضى كلهم يعرفون عندكم جليفيك او ما عندكم، يجي المريض يقول لك جليفيك عندك لو ما عندك تزعيماتنا، او ما يسمى بالنيلوتينب اللي هي المرضى يعرفونه باسم التاسجنا، او لا يجي المريض يقول لك انا اخذ تاسجنا بالطوارئ، يقول لك الدكتور انا ما يقول لك المريض بالطوارئ، من يجي المريض بالطوارئ ما يقول لك انا عندي سيمم، يقول لك ايش بيه؟ يقول لك انا عندي مرض بالدم، ايش تاخذ علاج؟ يقول لك اخذ جليفيك. من يقول لك جليفيك يعني سيمم، من يقول لك انا ماخذ تسجنه يعني سيمم. فلازم تحفظهم ذني الاسماء لان لهن علاقه بالتريتمنت مالتك وبالديسيجن مالتك تبعهم. السيمم هاي مهمه الجليفيك، وتحفظون التسجن. يقول لك عندي ايش بيك؟ الشيء اللي تفتهم منه الوحيد اسم الدواء، لان هذا الدواء كرونيك هو دائما ياخذه. عندكم جليفيك، اخذت جليفيك to know it. What is left from chronic leukemia? We already took the chronic leukemia. راح ناخذ فقط overview على chronic leukemia when the malignant clone is able to differentiate, but it is accumulated after differentiated. مشكلتنا بالacute leukemia failure، بالacute leukemia كانت المشكلة الرئيسية failure of maturation and accumulation of immature primitive cells. مشكلتنا بالchronic leukemia هو اكو هي accumulation of mature cells. When the malignant clone is able to differentiate and result in accumulation of more mature cells، راح تعطينا نفس النتائج، انه الماتشور سيل راح يصير بها accumulation، يعني of single malignant clone. هنا شو راح تفتهمونها؟ اذا افتهمنا احنا الاكيوت لوكيميا هم الاطفال الذين لا يكبرون وراح يتوزعون في كل مكان، راح يخربون البلد لان هم failure of maturation. بس هذا الماتشور سنجل كلون يعني شنو؟ يعني مثلا تصوروا انهم الاطفال يكبرون ويصيرون كلهم اطباء. تروح للسوق تلقى طبيب، تروح للمحكمه تلقى طبيب، تروح للمدرسه تلقى طبيب، تروح لاي مكان الجراج مال سيارات تلقى طبيب. يقدر الطبيب يوفر الاشياء اللي يوفرها المجتمع؟ اكيد لا. هذا الطبيب هو كلون، سنجل كلون. الحياه مبنيه على بوليكلوناليتي، بوليكلونال. جعلناكم شعوبا وقبائل، يعني كل مجموعه لها دورها بالحياه. الاطباء يقدمون سيرفيس، المهندسين يقدمون سيرفيس، المعلمين يخدم single cells، single clone، single maturation. ما راح تحصل نتائج. فمشكلتنا بالكرونيك لوكيميا هو اكو maturations، اكو سيلز، بس هذا الماتشور سيلز ياخذ نوع واحد من عندها ويسوي له accumulation. It's different influence. إذا acute leukemia هي مشكلتها time، هنا indolent الكورس مالتها. Most are asymptomatic at presentation بالكرونيك عكس الacute. The survival is usually years after the initial diagnosis. In certain chronic leukemia evolution مثل ما حكينا maybe switching from chronic leukemia to acute leukemia يصير بها ما يسمونه بالtransformation. فناخذ example of this patient عالية. This patient has a 64 and he has anemia and mild thrombocytopenia, and this is incidentally diagnosed. So when a blood film إليه, what do you find? إذا لقينا هناك بالCMR all spectrum of cells, and this leukemia, some cell is smudged, destroyed, smeared. This cells is destroyed like this. When you find a multiple destroyed cells inside the blood film, like a smudging cells, smudge cell is the clue of CLL, chronic lymphocytic leukemia. It's a clonal malignant of B cell lymphocyte. usually associated with lymphadenopathy, hepatomegaly, splenomegaly, typically affecting elderly above 65. The CLL is a chronic leukemia. We have, like CML, risk of blastic crisis and transformation to more acute leukemia. This CLL, again, may have a risk of transformation to acute leukemia and lymphoma. We call it a transformation, special transformation presentation, usually asymptomatic more than 5 in routine because of accumulation of the mature lymphocyte inside the marrow. The result will be thrombocytopenia and risk of infection due to acquired hypogammaglobulinemia. So the risk of horrible zoster in those patients are very high. We have صعب عليكم. How can you diagnose patient with CLL? What is the diagnostic technique you want to do in patient? We have a special technique, we call it a flow cytometry. What is a flow cytometry? Flow. We took a blood. Each cell, each lymphocyte in the blood. Cytometry, we have a measurement, a special measurement. Flow cytometry. This is a special technique that every cells have identification. Every cells have a differentiation, differ from other cells. So any cell enter the flow cytometry can be detect the abnormal cells accordingly. The flow cytometry can detect the CLL. When we go to the treatment, how can you treat patient with CLL? We are talking about percent of the cure. In chronic leukemia, we have no cure. So why do you treat? Why do you treat if you have no cure? The treatment, we just to keep the patient away from symptoms, just to improve quality of life. So the treatment is usually by chemotherapy away from symptoms, not to cure the patient. We have no facility of chronic leukemia is just to keep him symptom-free, to improve quality of life, and usually by chemotherapy. Treatment of CLL by chemotherapy, treatment of CML by TKI, Gleevec, and Tessig. So, any question?